Medurstand Understanding Medicine.
I am Professor Azizur Rahman, and in our discussion on ECGs, we have already covered up to uh, AV nodal block, and today we are going to take the next module in our curriculum, that is bundle branch block. This is the curriculum we have covered up to this, and bundle branch blocks is today's topic. This picture I showed you, and I'm sure you are all familiar, but because it is very relevant to today's discussion, we will very briefly touch upon it again. And you can see the structure. This is AV node, this is bundle of His. Then these are two main branches. This is the left one, which runs on the left side of the septum and gives a small branch to the septum, and then it bifurcates into left posterior fascicle, which is just a bunch of fibers, not a one discrete uh, uh, cord like structure, but this one, then this is anterior fascicle. This used to be called anterior superior because it comes anterior and then turns around upward and it supplies the upper part of the left ventricle. And then this one is the right bundle branch, and this passes on the right side of the septum and then turns around and supplies the right ventricle. Now, although both chambers have different conduction fibers, but actually current can go from one chamber to the other one. This is nature's blessing. Left ventricle is depolarized by the left branch and the right ventricle is depolarized by the right branch. But in case there is block in the right bundle, for example, current will first depolarize left ventricle and then the same current will go to the right side and will depolarize the right ventricle also. Although the right ventricle will get depolarized, but it will be after slight delay because the electrical depolarization is spreading from the left ventricle to the right ventricle, not through the specialized conduction system, but just through the normal muscle fibers. So the conduction time will be delayed and depolarization time will be delayed and QRS complex will be wide. Similarly, if you have left bundle branch block, then current will flow from the right side to the left side, and there will be special morphology because depending upon if the current is flowing from the left to the right or right to the left, there will be different morphology of QRS complex, and that we will use to diagnose if there is any bundle branch block. If there is fascicular block, this we will take up in the next module. In the fascicular block, there may not be any widening of QRS complex, but there is significant axis deviation. Whereas in right bundle branch block or left bundle branch block, we do not have significant axis deviation. So the pathology is somewhere here, distal to bundle of His in any of the branches, right or left. So right bundle branch block, obviously the problem is in the right bundle anywhere. Left bundle branch block, it could be in the main stem up to this point, or it could be in the posterior fascicle or the anterior fascicle. Then there is a condition called trifascicular block. And what is that? A trifascicular block means we actually have three fascicles. One is the right bundle as one fascicle, and the left anterior second, and the left posterior third fascicle. So any two fascicles, if they are blocked, it is called bifascicular. So for example, left bundle branch block, complete left bundle branch block is technically bifascicular block. But the block can be here or it could be in the both fascicles. And a right bundle branch block with any of the fascicles, either anterior or posterior, that would also be bifascicular block. Then there is a condition called trifascicular block. Trifascicular block would be complete, like that would be actually AV dissociation, that if the block is in bundle of His or both the branches, that would be trifascicular block, or it could be incomplete. Incomplete trifascicular block is diagnosed when we have bundle branch block pattern plus there is some prolongation of PR interval. This I might discuss in more detail later on, but I think for this video, this much is enough. Then we have non-specific intraventricular blocks. That means we cannot pinpoint where exactly the block is, but because of myocardial fibrosis, because of ischemic heart disease, maybe because of dilated cardiomyopathy, other cardiomyopathy, there may be multiple small blocks at multiple areas, and that might not take any particular shape of left or right bundle branch block, but there is some block, and that is manifested as broadening of QRS complex. So with this background, I'm going to take up first the right bundle and then the left bundle, and we will take fascicular block and other blocks in some other modules. Now let's do this exercise. This is an ECG, and like always we see the rhythm. First of all, we have to make sure that we are dealing with sinus rhythm, or at least supraventricular rhythm. Supraventricular rhythm is not necessarily the same as sinus rhythm, but I think for the purpose of our audience, we assume that the criteria is first we have to make sure that this is sinus rhythm. And what do you think? There is PQRS, PQRS, PQRS. It is repeating with regular intervals, so it is sinus rhythm. And then we see the morphology and the duration. I have drawn your attention to this complex. What do you see? This one looks slightly broader than normal, and the terminal part of the QRS, the downward deflection, the S wave, is particularly prominent. So QRS complex appears to be wide, and there appears to be an abnormal broad S wave at the end of QRS complex in limb lead 1. And then I draw your attention to this lead V6, and in this case the S wave is again wide, because technically 1 and limb lead 1 and precordial lead V6 both represent the left side of the heart. Now let's see what is happening on the right side. This is the V1 right sided lead, and you see here again the complex is wide, but there is an additional R wave. What is additional R wave? By definition, in a QRS complex, first upward deflection is R wave, and we have first upward deflection here, but then there is S wave. Normally there should not be, or there should be only a small R wave after the S wave, but in this case there is a prominent broad wave after the S wave, and this is called R prime. R prime is additional R. So what is R prime? This is any upward deflection in a QRS complex after the first R. Okay, so this is R prime. So what have we seen so far? A sinus rhythm, broad QRS complexes, and a deep S wave in broad S wave in limb lead 1 and AVF, and we have seen a unique broad complex RSR. R, initial R, then S, and then R prime. So this should lead to the diagnosis of right bundle branch block. Okay, so we have met the criteria. Now what are the criteria? I'll just show you. First of all, make sure the rhythm is sinus, right? Sinus rhythm, as I said, any supraventricular rhythm would actually behave the same way, but we assume that there is sinus rhythm, and we have demonstrated here that there is sinus rhythm. Second criteria is that QRS is more than its normal width, and normal is 0.11. So it is 0.12 or broader. 0.12 would be equivalent to 3 small squares. So if the QRS complex, total duration, any QRS complex, a bundle branch block should affect all QRS complexes. Although in some complexes it is easier to identify the start and the end of QRS complex, and in others it may not be, because part of QRS complex may be actually isoelectric. So if you have to identify a QRS complex where you can clearly identify the initial part, the end part, so that is a complex which should be used. and if it should be more than 0.12, and there should be RSR pattern. Now please note down on this complex, I have written R in lowercase because in this case the initial R wave is rather small in size. This S is in the is capital because S wave is fairly deep, and the R is again capital because secondary R is also quite prominent, and this little dash indicates R prime. Prime is something which is additional. So you have RSR pattern in V1. So I think the diagnosis is easy. If you have an ECG which has a sinus rhythm, QRS complexes are broader than 0.12, and we have RSR pattern in V1, this is enough to make a diagnosis of right bundle branch block. Now, what is RSR? All these patterns which I have drawn with hand, if the initial R and then deep S, the second R, both R's are equal, this is RSR, initial R, and then QRS complex comes downward. It does not even come to the baseline, but it rises again. Technically, this is then R, a prime. So this type of pattern, or both complexes upward with S wave not going below the baseline, or this one upward and there is only slight slur in the upslope. All these are examples of RSR patterns. It would be written in a different formats depending upon if the R is small in size. The small wave is written in the lowercase and the big wave is written in the uppercase. So this is actually the way it is written. But please note down any of these patterns in proper context, sinus rhythm, and this type of morphology in V1 should be diagnosed as right bundle branch block. We are going to repeat this exercise before we go to the left bundle branch block. This is another ECG. The same technique. First we see the rhythm. Let's see the rhythm. This one. If I have highlighted this strip, you go from this side to this side. Everything is nice, smooth. There is a complete PQRS repeating, no irregularity at all. So the first criteria is met, and then we will see the duration. This one I think is fairly broad, but I'm going to highlight it. I'm going to zoom in to show it in a better detail. Look this one. And if I draw these lines from the start of QRS complex to the end of QRS complex, this is 0.16. 0.16. 0.16 is way above the required. 0.12 was required, so it is 0.16 seconds. That means QRS complex is broad. Okay, so we have met the second criteria. Now we will have to see the morphology, and morphology in V1. You see there is deep, not exactly very deep, but fairly broad S wave in limb lead 1, and we have RSR pattern in V1. There's a small R, there's a big S, and then there's a big R, and fairly broad. So RSR pattern is there. I think this was just the revision of the last slide. The diagnosis is right bundle branch block. So I believe it is easy. Sinus rhythm, broad complexes, RSR pattern in V1, diagnosis is simple, right bundle branch block. Criteria I've listed here, and what are the causes of right bundle branch block? Sometimes it may be benign, and many times you just do an ECG for some reason and you find right bundle branch block. So we all believe that right bundle branch block could be just benign normal finding in normal healthy person, and if this is the case, you must explain it to the patient so that if patient hear the same from another doctor that there is a problem in the ECG, and suppose this patient develops some chest pain and goes to the hospital and first time right bundle branch block is diagnosed, that could actually raise an unnecessary alarm. So patient should know it. But it could be a manifestation of ischemic heart disease. It could be a manifestation of acute coronary syndrome, acute myocardial infarction. It may also be a manifestation of venous thromboembolism. Certain, if there is a new right bundle branch block, that is definitely due to some problem like ischemic heart disease or venous thromboembolism. So this was a right bundle branch block. Let's take this example. Same exercise has to be repeated. First we do the rhythm. In this case, rhythm is regular. Then we see the QRS complexes. They are definitely wide. If you remember the normal should be 0.10 or maximum 0.11, I think 0.10. That means smaller, equivalent to or smaller than 2.5 small squares. In this case, it is bigger. I'll again zoom in and show you the duration. And the morphology, see, in this case, we have RSR pattern in limb lead 1. And also we have RSR pattern in V6. In the right bundle branch block, we have RSR pattern in the right sided lead, which is V1. And in left bundle branch block, we have RSR pattern in the left sided lead, which is V6 and also limb lead 1. So the diagnosis in this case is left bundle branch block, and we do not have that RSR pattern in V1. I'm going to list the criteria and explain them further. So criteria are, number one, sinus rhythm. We demonstrated in this case there was sinus rhythm. Number two, broad complexes like more than 1, 2, and it is more than 1.12, and I'm going to show you it again. No R in V1. So up to this point, if we have sinus rhythm and complexes are broad, I think we are sure the patient has got either right bundle branch block or left bundle branch block, either of the two. Now there are two approaches. One is to rule out right bundle branch block. Since there are only two possibilities, if we have ruled out one, we will be left with the diagnosis of left bundle branch block. And this is that approach. No R prime in V1. In V1, after the S wave, there is no R prime. So that means there is no right bundle branch block. So that we can draw an inference that this is then left bundle branch block. And the second criteria is that you, rather than ruling out right bundle branch block, you look for the sign of left bundle branch block. That is this one, you look for the same RSR pattern, but this time you look in the left sided lead, and we can look in the V6 or limb lead 1. So I'm going to do it here, and there is RSR, R in the uppercase because initial upward deflection is big, then S in the lowercase because S is actually this indentation is to be called S because it is downward, but it doesn't even come to the baseline. It doesn't go below the baseline. A true S wave actually goes below the baseline, but this one which comes down doesn't even reach this baseline. It should be called S wave because of the second rise, which is R prime, and the second, after that initial indentation, the second one is R prime. So this, technically speaking, is an RSR pattern in V6. So this actually fulfills the criteria. If you want to go a step further, then the next criteria is absence of Q wave in left-sided lead. Now I'm talking about the normal Q wave here. And let me give you an example. If you take my case, this is the position of my septum, and it is depolarized from left to right, and this depolarization wave is recorded as downward deflection in all left-sided leads. In one in AVL and left-sided precordial leads, it will be recorded as slight downward deflection, slight small Q wave. Okay, that is a normal Q wave, but sometimes it is not present. So if you develop left bundle branch block, because the septal branch comes from the left bundle, so if the left bundle is blocked, then septal depolarization will also not occur the normal way from left to right, and this Q wave will become absent. I hope I was able to explain this. If you have difficulty, you can pause the video, repeat it. So then you will understand. Normal septal depolarization, which is shown as a small Q wave in left-sided lead, that may disappear. So that is another criteria. So if you fulfill all these criteria, you can make a very definite diagnosis of left bundle branch block. Unlike right bundle branch block, left bundle branch block is usually considered to be a sign of some disease, either ischemic heart disease or some other heart problem. So this is to magnify it, and you can see it. How many squares? 1, 2, 3, and 4. 4 is 4 into 4, again 16. So it's a fairly broad. Actually, this is the part of the complex in the upper lead. You just ignore this part. So these are the complex. You, I think, concentrate here. QRS complex is definitely broad. Like in right bundle branch block, in left bundle branch block, all complexes will be broad, but you will choose the one which has got very sharp start and end so that you can correctly calculate the duration. This is another ECG, a revision. Now you just see the same thing. First the sinus, first make sure it is sinus rhythm. Nice PQRS relationship. So it is sinus rhythm. And the second thing is we see the duration. These, for example, waves, they look definitely broad. All are broad, but this one is quite easy to appreciate. Let's zoom in and see it in greater detail. This is the one. So this is the same wave V5. I have magnified it, and you can see the duration is 0.16. Okay, so it is broader than normal. And what is the next step? Next step is we see the morphology in V1, in limb lead 1 and in V6, left sided lead, and there is RSR pattern, and this is actually RS pattern in any of the left sided lead. It could be V6 or V5. You see, this is V5, this is V5, and you would agree with me, this is RSR pattern. And if you have to write it down, it would be R capital, S lowercase, R uppercase, S lowercase, and then R prime again uppercase, because these two are big ones. So that would be RSR pattern. This is actually again left bundle branch block. Let's see one more revision, do one more revision, and then we'll conclude this module. See this one, I think I'm not going to show any further hints here. Sinus rhythm, broad complexes, broad complex here, broad complexes everywhere. This is RSR in one, lead 1, RSR in V6. So this is surely left bundle branch block. And PR interval is normal, so there is no bifascicular or trifascicular block. With the same criteria, which I have discussed earlier, so I'm not going to repeat them. And the causes of left bundle branch block are ischemic heart disease, and left bundle branch block may also be benign in some cases, but generally speaking, it is considered to be a sign of heart disease. New onset is equivalent to STEMI. Now, this is important. If you know that there's somebody who did not have left bundle branch block, and the bundle branch block, left bundle branch block appeared with other symptoms of acute myocardial infarction, so you know that this is a new onset left bundle branch block. Even in the absence of ST segment elevation, this should be considered as sign of ST segment elevation myocardial infarction. And we expect that in this setting with treatment, left bundle branch block will disappear. And it will also affect left ventricular function. Why? Because in order to be effective, left ventricle should contract as one chamber and in a one effective synchronous movement. But in a left bundle branch block, since the current doesn't spread that fast, it takes some time. So the contraction wave starts from one side and ends in the other, and so the contraction is not that effective. It might actually reduce the stroke volume, maybe very small percentage, but that is, I think, clinically significant in those patients who have heart failure. So the summary, if you compare a right bundle branch block and left bundle branch block, this is the summary. This is the right bundle. You see what we call rabbit, I think a rabbit ear sign, and this is two ears of rabbit. If you have this sign present in right-sided leads, this V1 is right-sided lead. We have right bundle branch block provided there is a sinus rhythm and QRS complexes are broad. And if you have the same pattern in the left-sided lead in V6, that would be called left bundle branch block. If you want an easy approach, this is the one, but I never like these shortcuts. I want to learn the actual disease and I want to explain the same to you. So I have done that. I hope you have understood that. So this was a brief review of bundle branch block. In the next module, we will take up the fascicular block. This is Professor Azizur Rahman from my channel Medurstand. Please keep joining and keep enjoying and keep learning. Thank you very much. I really look forward to see you in my next video. Professor Azizur Rahman.